The next part of this lecture is about the facial nerve paralysis. Before we discuss the causes and the classification of facial nerve paralysis, let us first review the functional anatomy of the nerve fiber. So, the axons here are bundled together into fascicles. So in these illustrations, there are three fascicles. No? So an individual axon is surrounded by the endoneurium, and the entire fascicle is enshaped by the perineurium, no, which serves as the blood and the nerve barrier. And the epineurium surrounds the entire nerve, holding these structures together. When an axon is injured, the biochemical and histological changes occur in the cell body proximal and distal to the site of the injury, and the severity of the changes depend upon the distance from the injury to the cell body, the type of injury, the age of the patient, and the nutritional and metabolic status of the patient. Proximal injuries usually are more severe than distal injuries, and crushing injuries are more severe than clean transections of the nerve. And older individuals sustain more severe injury in the nerve than the younger patients. The extent of nerve injuries is classified commonly through the Sutherland classification. The first degree of nerve injury, also known as neuropraxia, this involves a localized conduction block in the nerve with the nerve fibers responding to electrical stimuli proximal and distal to the lesion, but not across the injured segment. The physiologic neural block is created by increased intraneural pressure. In, in this condition, the axonal continuity is preserved, and the Wallerian degeneration does not occur, and the recovery is usually complete. Clinical recovery usually begins by 1 to 4 weeks after the injury. In the second degree of nerve injury, there is loss of structural continuity of axon with intact endoneurial sheath. No? And if the compression is not relieved, there is loss of axon and the occurrence of Wallerian degeneration. So this condition begins within 24 hours after the injury and is complete within a few days, usually 3 to 4 days. No? So there will be loss of excitability to stimuli completely after 3 days. Complete recovery will occur if the process is reversed, no? If the pressure is withdrawn. However, it would take longer, no, as it would occur after 3 weeks to 2 months, and this is provided that the endoneural tubes are intact. If the connective tissue elements remain intact, the axon may regenerate at a rate of 1 millimeter per day to the original end organ, with the potential for complete recovery. Third degree nerve injury or neurotmesis occurs if there is loss of continuity of the axons and the endoneurial sheaths. So there is marked reduction in response to electrical test, and spontaneous recovery will not be noted for 2 to 4 months. Synkinesis may result due to faulty regeneration of the nerve. So, when we say synkinesis, this is a neurological symptom in which a voluntary muscle movement causes the simultaneous involuntary contraction of the other muscles. In the fourth degree of nerve injury, there is partial transection of the nerve fiber, and there is loss of continuity of the axons and the sheaths. So we cannot expect a spontaneous recovery of the function of the nerve. The best results come with surgical repair at the earliest possible moment after the injury. And if it recovers its function, it is never as good as that of the first 3 degrees of injury. In the fifth degree nerve injury, there is complete loss of nerve continuity, and it offers almost no hope for useful regeneration unless the ends of the nerve uh, are surgically repaired or reapproximated. So this is the table that summarizes the Sutherland classification. Mm. So first degree, there is compression with normal EMG response, and recovery begins after the first to 4 weeks after the injury. In the second degree, um, recovery within 1 to 2 months. In the third degree, 2 to 4 months. In the fourth degree, 4 to 18 months. However, in the fifth degree, there may never be recovery of the function of the nerve because the scar field gap prevents regrowth of axons. So what is important is that uh, earliest repair of the nerve after an injury uh, can help, no, can greatly help in the recovery of the function of the nerve. When a patient comes uh, into the clinic with a facial nerve paralysis, the history of the patient is very important in determining the cause and the prognosis of the condition. So, during history, it is important to ask the onset and the course of the facial nerve paralysis. We need to know if the patient has history of otologic problems, or if the patient has ear or parotid surgeries, and if there is injury or trauma to the head or the temporal area, and also if there is presence of neurologic diseases and infections, especially in the ear, no, and also presence of tumors in the parotid and the temporal bone. So any conditions that would affect the facial nerve in its course, no, from the brain towards the parotid area should be evaluated or should be investigated. So patients with facial nerve paralysis usually present with facial weakness. Some of them would show hyperacusis, no, or there's heightened sensitivity to certain sound frequency. This is due to the paralysis of the stapedius muscle. Also, patients would complain of gustatory disturbances and disturbances of lacrimation. Usually, there is dryness of the uh, mouth also and of the eyes. So part of the evaluation of the patient with facial nerve paralysis is to assess the motor responses of the facial nerve branches and to compare it to the other side. Okay, We know that there are five branches, major branches of the facial nerve. These are the temporal branch, zygomatic branch, buccal branch, and marginal mandibular branch, and the cervical branch. So we test them by the following. No? We ask the patient to perform this activity. In each time we ask the patient to do this, we need to compare it to the other side. Uh, so here we see a patient with a facial nerve paralysis on the left, no, with incomplete eye closure and inability to lift the corners of the mouth. We classify the paralysis through the House-Brockman facial nerve grading system. We grade them 1 if there is normal facial function in all nerve branches. 2 when there is slight paralysis. Uh, there is normal tone and symmetry at rest. However, there is a slight asymmetry of the mouth with complete closure of the eye with minimum effort and a good to moderate movement of the forehead. In grade 3, it is moderate with normal tone and symmetry at rest. However, there is a slight to moderate movement of the forehead and there is a complete closure of the eye only with effort, and the mouth is has slight weakness with maximum effort. Grade 4 is moderately severe, and grossly there is the symmetry is disfiguring and there's obvious facial weakness and there is no movement in the forehead. If you ask the patient to lift his eyebrows, no, and there is incomplete eye closure. Also, the mouth is asymmetrical. Grade 5 is severe. There is only slight, barely noticeable movement of the facial muscles. There is no movement of the forehead and there is incomplete closure of the eye, even the maximal effort, and the mouth has slight movement only and maximal effort. And the grade 6 is the total paralysis. No? There is no facial function at all. Other tests that can be done are the following. One is the stapedial reflex testing through tympanometry. This is just to test the stapedius muscle. Schirmer's test, no? Um, Also taste testing and electromyography. Electroneurography, or ENOG, involves supramaximal stimulation of the nerve trunk and measuring the muscular response with surface electrodes. So the degree of degeneration is expressed as a percentage relative to the healthy side. Now, imaging studies can be done, especially if you suspect tumors in the brain, no, or in the temporal area and the parotid area. So CT scan and MRI can show the site and extent of the lesion.